about recovery from C-section. So let's talk about that for just a minute. So in the hospital postpartum, the first day after you deliver is the hardest day. Like you feel like you were hit by a truck trying to get out of bed the first day after a cesarean. And that is just because you've been in bed, right? You've been in bed for sometimes 12, 24 hours. Your muscles are getting a little bit stiff. If you were in labor for a long period of time, you're tired. And then the recovery process has to start. So the recovery process actually takes weeks, but the initial recovery, the nurses are going to tell you, you got to get up, you got to start walking, you got to start moving around. So recovering from a cesarean is not that much different, other than obviously you have an incision. So there will be a bandage over your incision that comes off first day post-op. And then it's a matter of being able to do all of the things that you need to do. How do you do that? With pain medication, right? The pain medication that's offered post-op are narcotic pain medications, and then analgesics like Tylenol, Motrin. Tylenol works better for incisional pain. Motrin works better for cramping. And then some women actually need medications like Dilaudid or morphine to actually help with incisional pain. So that is offered to you post-operatively, short period of time. If you're breastfeeding, you want to get off narcotic medication as quickly as you can, because that will be passed in the breast milk, and we don't want the baby to get too much narcotic medication through our breast milk. So recovery from a C-section, I think the hardest thing for people is they don't expect to feel burning. You're going to feel burning in the corners of your incision, the very corners of your incision. You're going to feel burning for several weeks post-operatively, not for several days. So anything you do, you get up, you twist, you turn, you get up, you lift your leg, you're going to feel burning in the corners of your incision. That's actually quite common. We tell moms, I don't want you driving a car for 2 weeks post-operatively. We don't want you to be doing any heavy lifting other than the baby, nothing heavier than the baby for the first 2 weeks post-operatively. So you want to make sure that you have some support, some help to be able to do things like the grocery shopping and the laundry and that kind of stuff at home, so that you're not doing too much. You can go up and down stairs post-operatively. That's not a problem. If you're going to go upstairs, you stay upstairs for a little while. If you're going to come downstairs, you're going to stay downstairs for a little while. So the recovery is just a little bit harder because of your incision, but you're still going to be able to recover. And most women actually feel okay after a C-section. It's just post-op day 1. After that, most people get around and they do just fine. But that's an excellent question. Is erythromycin ointment needed for a C-section birth? Aisha, that's a great question. So in some hospitals, it's actually considered routine and it's just given. Could the baby have an infection inside the uterus? It's possible, but not likely. So you could very much say, I really don't want the baby to get the erythromycin ointment if you feel strongly that you don't want them to have it. When I had my kids, to me, it was a very low intervention that could provide some benefit. So I had no issues with my kids getting the erythromycin ointment. But you certainly could say, I don't want the baby to get the erythromycin ointment if the baby didn't go through the vagina. That's perfectly acceptable. Okay. Okay, Diana has a great question. May you kindly talk about the risks and benefits of laboring down? So what laboring down is essentially not pushing immediately when somebody is 10 centimeters. And here is the benefits. If somebody has an epidural and they're quite comfortable and you can let the uterus just help the baby to labor down, it may shorten the second stage of labor. You may not have to push as hard. If somebody does not have an epidural, laboring down is actually quite difficult because the urge to push is actually so significant. So laboring down is something that generally happens when people have a epidural for their pain relief. Now, there was a statement that came out by the American College of OBGYN maybe 2 or 3 years ago that actually said, looked at the benefits and risks of laboring down. And what they said was, although it's a common practice to just let mom have an hour or two after she's fully dilated to let the baby sort of ease down into the pelvic canal, into the vaginal canal, and push for a slightly less period of time, the risk for obstetrical hemorrhage increased in patients that were laboring down. So it was considered a little bit safer for mom to decrease the risk of hemorrhage if she started pushing when she was fully dilated. It really depends on where you're delivering and your obstetrical care provider, whether they labor down or not. And sometimes it depends on how long somebody's been in labor, whether I'll make the decision to just let mom labor down. If I know that she got an epidural, she's exhausted, tired, and she's fully dilated, she feels no urge to push, I might say, let's give it an hour. Let's see what happens in an hour. An hour of laboring down is not really going to increase the risk of hemorrhage like laboring down for 5, 6, 7 hours, letting somebody sleep all night long and then push in the morning. That I don't love, because I think that can increase the risk for bleeding postpartum. So there's definite benefits if it's done sort of for a shorter period of time. I think gives mom a little bit of a chance to rest before she has to push. But I can't neglect the fact that there was a statement that said laboring down can slightly increase the risk for bleeding. So great question. Okay, why might induction be needed at 40 plus? Great question. Okay, so induction, once you hit 41 weeks, so up to 41 weeks, 7 days past your due date, which by the way, 85% of all patients will deliver by the 41st week. If you get to 41 weeks, there are no increased risks to you or the baby. So it is reasonable to let a mother stay pregnant for 41 weeks. So here is what happens with your risk, right? 37, 38, 39, 40, 41, now 42, right? The risks really start to increase the closer you get to 42 weeks. And those are all things that you probably don't want to be induced for. But when we look at that 41 week mark, right? When we get to the 41 week mark, most people are saying, I don't want a C-section. That's why I don't want to be induced. But past 41 weeks, the risk for C-section increases anyway, simply because you're now post dates. There can be a higher risk of fetal intolerance to labor, which increases your risk for C-section. There can be an increased risk for meconium-stained fluid, which increases your risk for C-section, increases the risk of the baby having to go to the NICU. So all of those things, there can be a decrease in the fetal amniotic fluid. That increases your risk for C-section. So once you get to 41 weeks, in between 41 and 42, your risks start to increase for all of the things that you don't want to happen. So a lot of providers will say 41 weeks is my cutoff. Some say 40 weeks is their cutoff. I would tell you 41 weeks is probably a good time to really sit down and then say, okay, is there a benefit to staying pregnant at this point, or is the risk of staying pregnant greater than the possible risk of C-section from induction? I would say at 41 weeks, the risk of induction is actually lower than the risk of C-section. So I discuss that with my patients all the time. But that's why would I'm guessing, I'm now thinking you're saying, why would an induction be needed at 40 plus years of age? Maybe that's what you're saying. Let me answer that too. So we know that women who are 40 years of age or greater have a higher risk of stillbirth than women who are under. And for that, and there's a greater chance of the placenta not functioning as well the closer you get to 40 weeks and beyond for women who are 40 years old and older. There's more fetal testing that happens in the last several weeks of pregnancy for that reason. And because we obviously don't want any woman to be in a situation where there's a stillbirth or significant risk of stillbirth. That's why the recommendation is made for women who are 40 years old or more to consider induction at 39 weeks. So that is that's been in place for, I'm going to say, I don't know, maybe 4 or 5 years from the American College of OBGYN. Okay, cord clamping. When does the timer start? When the baby comes out. So when the baby comes out of your body, the timer starts. Okay, can you tell us about the shakes after C-section? Okay, so it is very common after vaginal delivery and C-section to have like uncontrollable shaking. And what that is simply your body's natural catecholamine release, hormone release after delivery when you've been through something very stressful, surgery or vaginal delivery. So it's very common to kind of have the shakes. for about an hour to an hour and a half after delivery. If it's significant, then sometimes there are some medications that can be administered. More often than not, medications aren't even needed. We just give moms, comfort for support. Sometimes we use a warm blanket, even though those shakes aren't due to being cold. It is really just a natural hormone release. So they get better over time. But it is quite common to have uncontrollable shaking, not just after a C-section, but after a vaginal delivery as well. Okay, do we get a urinary catheter with epidural? Yes. In almost every circumstance, an epidural catheter necessitates the need for a urinary catheter because you won't feel your bladder filling up. Okay. Is it okay to get an epidural if you've had low blood pressure throughout pregnancy? Yes, Leanna, it is okay to get an epidural. Usually what happens is the nurse will, through your IV, start administering a liter or two of fluid before the epidural is actually placed. So that is very commonplace, and that is done in essence to decrease the risk of that blood pressure drop that happens. So we usually load moms up with some fluid to keep the blood pressure from dropping. But even if you have low blood pressure, pardon me, it is fine. It's absolutely fine to get an epidural. Okay, with C-section, how is the placenta removed? Great question, Rosie. So with a C-section, because we've taken the baby out of the uterus, what the obstetrician will do is simply manually put their hand inside the uterus and peel the placenta off the wall of the uterus, and they manually remove it. They take it right out of the uterus. Okay. Do we have any recommendations on whether or not to donate cord blood? So the question is, do we donate cord blood? Do we bank cord blood? So banking your cord blood is essentially like an insurance policy. What happens with banking cord blood is you work with a private company. If you Google banking cord blood, you're going to get hits right away. There's usually three main companies: LifeBank, CryoCell, Viacord, and there are companies specific to the areas of where you live as well. So those companies will pop up. There's a fee that it ranges anywhere from $750 to $1,500 to just to do the collection and bank it. And then there's usually a yearly fee every year up until your child turns 18. So when you decide to bank cord blood, what you're doing is ensuring that if you ever need it, and it's not likely that you would need it, but if you ever need it, you have it on hand, right? You have it on hand, and if you ever need it, you can use that baby's cord blood. If they have any type of disease that would necessitate the use of stem cells, you're ensuring that you have it. So it is like an insurance policy. When you're talking about donating cord blood, I say, why not? If you have the option to donate cord blood, yeah, donate it. If you're not gonna use it and you're not gonna bank it, I think there's a lot of benefit to donating cord blood because there's so much ongoing research right now about like how we're using stem cells for so many different diseases: Parkinson's, spinal cord injuries, just a few, but there's several other ongoing studies where we use stem cells, and that's, banking cord blood or donating cord blood allows that research to continue. So I do feel like it's a really great thing to do if it's something that you're open to. Okay. Any experience with patients who have hyperthyroidism during delivery? Yeah, a lot of my patients have hypothyroidism and hyperthyroidism as well. So it's really not as significant an issue as I think patients think it is. With hypothyroidism, as long as you're taking your medication, you're essentially fine. It's with hyperthyroidism, there can always be, some risks during delivery, but as a general rule, we don't see, unless there's like, a really prolonged labor or somebody has significant hyperthyroidism, then sometimes, there can be some slight increased risks, some cardiac issues that can happen. And sometimes we have to do an EKG. Sometimes we need a cardiologist involved. But again, like, I don't want you to worry yourself about that. I would have that discussion with your provider beforehand, before you go into labor, and just say, hey, listen, do you have any concerns? Do you have any risks, that you're going to be thinking about with somebody like me, during the course of my labor or delivery? Do I need to have a consultant? Do I need to have my endocrinologist consult with you prior to delivery? Where I practice, because I live in an area where we have a lot of women who deliver at a much older age. We have a lot of women with sort of comorbidities, and thyroid issues are one of them. So in my experience, in the 30 years I've been doing this, very rarely is are thyroid issues problematic in pregnancies. But I would have that discussion with your provider for sure. Melissa, great question from Melissa. Can scoliosis cause an issue with an epidural? So yes, 100% scoliosis can sometimes cause an issue with an epidural. So if you have scoliosis, you might want to have an anesthesia consult before you actually go into labor. You might want to ask your obstetrician or midwife, can I have a consult with the anesthesiologist to discuss this beforehand? So your anesthesiologist or your anesthesia team can actually talk to you about, how significant is your scoliosis? Did you have to wear a brace? Did you need any kind of rods placed in your spine? All of that. And then they're going to tell you, yes, an epidural is possible, or it is possible that an epidural is not going to be possible for you. And you want to know that before you go into labor. The last time, you don't want to find out that you can't have an epidural when you're asking for an epidural in labor. So that's an indication where you might want to speak to an anesthesiologist beforehand, and your care provider should be able to provide that for you, that consult. Okay, what monitoring is done for gestational diabetes in labor? Great question. If you take insulin for your diabetes, then you will usually have what's called an insulin drip. So insulin is run if your blood sugar falls below a certain level or goes too high. If you are diet controlled diabetic, we usually check blood sugars either on an hourly or every 2-hour basis during the course of your labor, and then adjust giving insulin if needed, or just giving some extra fluid with some sugar if need be, give a little bit of glucose if we have to. So it's usually just blood sugars that are done on a very routine basis. Ask your OB care provider how often that is, because it does vary from care provider to care provider. Okay, Craig, if you refuse to get induced, are you in pain and eventually spontaneously deliver? Great question. If you don't get an epidural before induction, can you get one after? I'm not sure if I understand that part of the question, but I'll answer to the best that I can. Is there a situation where they would give you a choice between getting induced and getting a C-section, which is preferable? If you're asking me which is preferable, I would say induction over C-section is preferable, because with induction, at least you have a chance at having a baby vaginally. So I think that would be preferable. If a baby can come out from the vagina, that's how babies are meant to come out of our bodies, I would prefer that. Sometimes that's not possible, and then a C-section is warranted, and then it's medically necessary. If you refuse to get induced, are you in pain? No, you're generally not in pain. You may not spontaneously deliver. So here are the risks if we're talking about post dates, right? Past your due date. If you are going into labor, or let's say you're not going into labor, and provider is saying, I really think you need to be induced to prevent against post-dates complications. I have been in situations where, yes, I've had people that have refused induction and spontaneously gone into labor, and then thought that their body did what it should have done, and they were maybe 42 or even 43. I had a patient one time, 44 weeks pregnant, went into labor, beautiful delivery, she did fine. I've also had situations where patients have refused induction, and then they come back for an appointment and their baby doesn't have a heartbeat, at 42 or 43 weeks. So doing this for 30 years, unfortunately, you see all of those things. So for me, I really don't recommend patients go past 42 weeks. I don't even like past 41 weeks, especially with women that are advanced maternal age. So I think that, if somebody refuses to get induced, you have to know, again, that brain decision making process. Like, what are the benefits? What are the risks? What are my alternatives? What happens if I do nothing? And I think if somebody decides not to get induced, you gotta own the risk of doing nothing, right? You have to own it. So if somebody says to me, I absolutely am not going to get induced for any reason, I need to hear them say, Chris, I heard you say that there's a chance of stillbirth. However small it is, I've heard you say there's that chance. That's a hard risk to own, I think, sometimes. If it happens, to think that there was, I guess, there were things that could be done to have prevented that from happening. So I've had moms where that's happened, and that can be really traumatic. So I think you just have to think about that brain method of decision making, and at the end of the day, what's going to work best? What's going to work best for the laboring or the non-laboring, right? The mom. Okay. Have I heard about neck? Yeah, necrotizing enterocolitis. Absolutely, I've heard about neck. It is not a good situation. It is not something that you want to have happen to your baby, for sure. I'm not going to get into it right now, just because I want to get through some of these other questions that are about birth in and of itself. If I have time at the end, I'll definitely talk about it a little bit more. Okay, Brianna, in your experience, what are the best ways to help mom coping with the stress of anxiety of potential complications? Yeah, focus on the positive instead of the negative. So, look, there are risks to everything, right? There's risks to getting in a car. There's risks to, crossing the street. What I try to tell my patients is, you take away from the magic of labor, right? If you constantly worry about the fear of what can be. And I think that's true in any situation. When people are riddled with anxiety and fear of what could potentially happen, you're not really living in the moment, right? And labor is something that you really want to live in the moment. You don't want to be fearful. What I tell my patients is, you let me worry, right? If I'm worried, I'm going to tell you I'm worried. You let me do the worrying for you. What you want to do is make sure that you have a relationship with your OB care provider that is rock solid. You trust that provider in and out, so you know that you're going to be well taken care of. And if there's any doubts in your mind, then you need to maybe interview some other providers where you're going to feel more comfortable. I tell my patients all the time, like, you got to trust me. You got to trust that I know, what you want, number one, and the safest, best way to get you as much of what you want as I can, while still paying attention to what is safe for you, right? So it really is more about living in the moment than it is all the fear of what could potentially happen. I really feel like, yes, there has to be some element of self-talk, being able to talk yourself down, right? If you can talk yourself into the anxiety, you can talk yourself out of it. And it has to be, how realistic is what I'm afraid of? What's the likelihood that's going to happen? How can I stop myself from thinking of all these things? And discussing that with your provider as well. I mean, it's one of the things I think midwives are great at, right? Being able to kind of talk people down, and making sure that you have adequate support around you, so that if you start feeling really anxious, you have support to be able to say, okay, you're getting in your head a little bit, right? The squirrels in your head are starting to run. So we got to calm it down a little bit. Think about what's the likelihood that those things are going to happen, and the probability that it's going to happen. The likelihood is that it's not likely. Does that make sense when I say that? I hope so. Okay, CBD oil or gummies safe or okay to help relax during pre or active labor. So there's not a ton of research on CBD in labor or in pregnancy. So I would tell you that it's something you have to discuss specifically with your care provider. With my patients, I've had people ask me specifically this question, and I usually say, because I don't have a lot of research to be able to tell them it's safe, that I usually don't recommend it specifically for that area. It's the same way I tell somebody, while in certain countries, CBD is used routinely, or alcohol is used routinely, in this country, we usually just don't recommend it. Okay. How long after baby is born until baby should be cleaned off? Sometimes it's immediate. Baby comes onto your belly and they just kind of wipe baby off just initially, put a blanket over baby, and baby stays on your chest. Baby usually gets a bath somewhere in the first 8 hours after delivery, but you certainly have the option to decline the bath. You could wait until baby goes home if you wanted to. All right. Any experiences with patients who had a seizure disorder during labor? Absolutely. Yeah. Some patients who have seizure disorders during labor, if somebody seizes during labor, then we have medications to control that. But generally, patients with seizure disorders actually do quite well in labor. We just know that somebody has a seizure disorder and we have medications on hand that we use to, stop a seizure if it were to happen. There's Valium, there's Ativan, there's magnesium sulfate. So there's lots of medications that we use to stop seizures if they happen. But truthfully, most women who have seizure disorders, it's never even an issue when they're in labor. They do quite well. Okay, does perineal massage prior to labor starting around 35 weeks help to prevent tearing and episiotomy? So I think that the best time to do perineal massage, truthfully, is when the head is actually dropped to the point where it's almost crowning. Otherwise, the perineum is quite thick. Is it going to hurt you to do perineal massage? Absolutely not. Your partner would simply, with a little bit of olive oil or coconut oil on the fingers, stick the fingers in the vagina, and with a very, very steady pressure, just for a few minutes, kind of put a little pressure to the perineum and just, swipe the fingers from side to side. But it can be painful for the woman, right? It can be painful. So it's just something that you're certainly open to doing. I think that perineal massage does minimizes the chances of having the need for an episiotomy or tearing. But do I think that doing it prior to 35 weeks reduces the risk? In my experience, it doesn't. Okay, at what point prior to delivery do we stop baby aspirin? That is a question depending on what you're taking baby aspirin for. I'm going to punt to your OB care provider. So sometimes baby aspirin is used for preeclampsia or to minimize the risk of preeclampsia, and those women continue baby aspirin right up until the day they deliver. But since I don't know a little bit more about your case, I would say ask your OB care provider. Great question. Okay, does breast pumping at 38, 39 weeks help induce labor? Yeah, I would have you discuss that with your care provider as well. There are some women that will put a breast pump on just for some nipple stimulation to help, bring on some contractions. I still say the best way to induce labor is to engage in regular sexual intercourse after the 37-week mark. Just and have your partner ejaculate inside and hold that semen in the vagina for a couple of minutes before you get up to clean up. That's probably the best way. But sure, could you put a breast pump on? Absolutely. But again, remember, we can't monitor the baby, so we don't know how the baby's tolerating those contractions if you end up having prolonged contractions. So that's just something to think about. Definitely, I would discuss it with your care provider. Okay, let's see what time it is now. Why don't we take 45 minutes? Right now, I have 4:20 my time. So let's come back. Why don't we come back 5 p.m. Eastern times, just under 45 minutes, and that should keep us on time. So we'll take a little bit of time for lunch or a little bit of a break, and I will see you back at 5 p.m. Eastern time. All right, we'll see you guys soon.